So, according to Google, if you use it in regular cooking as a substitute of common salt, it can control all health problems posed by common salt, like high blood pressure, puffiness in the eyes or the body, is cooling for the body, helpful on digestion, relieves gas, soothes heartburn, helps in weight loss. Not only health, but many beauty benefits can be acquired from rock salt.
I don't know why I spent all these years in medical school. I could just prescribe everyone rock salt.
So we thought we might try and educate her a little bit about what, how salt is salt.
Right.
Maybe she would follow our recommendations and perhaps try and cut back a little bit on that.
That's a great suggestion. Or meeting a dietitian to help us out too, because we work in teams.
And the exercise issue for her, she doesn't seem to, so just asking if she could integrate that into her lifestyle.
Right.
As a dietitian, my take-home message is eat more vegetables. And I think, especially with this population, I find their diets are really carb-heavy with the breads and the rice and the potatoes and the starchy vegetables. So I would definitely push more vegetables.
Yeah, it's funny. I told a patient eat more veggies, and she's like, "Is that before or after I go to McDonald's and Burger King?" And but it's in complement with it.
And congratulate her on not smoking and
Right.
assess her alcohol intake.
Excellent. Yeah, I think that's great. We talked about diet and lifestyle modifications. Any thoughts on the medications? Very good.
Oh, sorry. So she's on that sort of triad of maybe problematic for her blood pressure. So I maybe suggest maybe some Tylenol, says ibuprofen.
Right.
For primary prevention of cardiovascular disease, she doesn't need to be on an aspirin. So maybe she'd be pleased to know that she can actually get rid of a pill. And then maybe combine the hydrochlorothiazide and ramipril in a combination product.
Combination pill.
Yes, and we were going to tell her to give the Indian pickles away to other people and to make gooseberry pie with potassium-rich fruits.
Excellent.
Which would help equalize the sodium.
So this is called individualizing healthcare. It's awesome. It's not a cookie cutter approach. So I think amazing suggestions. We're going to come back to all of them, including even the ibuprofen. We all know NSAIDs are not great. GI bleed risk, cardiac risk, renal function risk, but it just works so well in some patients with arthritis. But starting with Tylenol, I think an amazing suggestion for sure. In terms of, go ahead, sorry.
Can I just jump in about the aspirin? So for patients with hypertension, is the one area where we really do have good primary prevention data that aspirin does help to prevent events when we use it in patients with hypertension that are already controlled. And that information came from the HOT study, the hypertension optimization trial. And it looked at 20,000 patients, and half were randomized to aspirin, half were on placebo. And there's a dramatic reduction of thrombotic cerebral vascular events. So that's led us to preserve the aspirin recommendation for hypertensives. Now, that's not the case in diabetes. And the data for diabetes is that aspirin as primary prevention doesn't work. But people forget that issue for hypertension.
And is that hypertension irrespective of age? I mean, we have a few 30, 40-year-olds in my practice who have hypertension. Thinking of putting them on aspirin at such an early age makes me a bit skeptical.
I can't remember what the youngest age was for the HOT study, but it was pretty young.
Okay.
I want to say 50, but it could have actually been into the 40s.
Right. And with diabetes, they say aspirin is potentially indicated if they have diabetes, obviously, in addition to another cardiovascular risk factor, which many of them do have. So it's very clear for secondary prevention to put them on aspirin if they've had a previous heart attack or stroke. But primary prevention, definitely we are generally moving further away from it. But there is evidence in hypertension or diabetes with another coronary disease.
Age cutoff was 50?
50 and over for the HOT study. Okay. So a patient who has hypertension over the age of 50, based on the HOT trial, would likely benefit from aspirin for primary prevention. Great suggestions. You guys should write the slides. Okay. So we'll go over some options that the authors came up with. So options would include increase the dose of ramipril. Again, she's on 5 milligrams. You could potentially go up to 10. Increase the dose of hydrochlorothiazide. She's on 12.5. You could potentially go up to 25. Increase the dose of both ramipril and hydrochlorothiazide, or recommend improvements in lifestyle habits. So again, all of these are correct in different senses. I would probably argue in her case that D would be the best option. I think that's what most of the group came up with. So There's no doubt that increasing the dose of ramipril will likely further decrease her blood pressure. Increasing her hydrochlorothiazide will also likely further decrease her blood pressure. We know that increasing both medications to full dose will have a larger additive effect in decreasing her blood pressure. And both medications have complementary mechanisms. They're better, again, in that single pill combination. So, I'll be honest, in practice, I probably will do one at a time. And we have the beauty of seeing our patients back in continuity of care. And blood pressure is a bit of a roller coaster ride. So it's not incorrect if there's systolics more than 20 or diastolic more than 10 to start two agents. So potentially, both of them could be increased. But again, tailoring it to your patient. And I think I would argue this would probably be the best answer in my mind, is really understanding her lifestyle habits. So I teach all our med students and residents, and even for their family medicine exam, it's always focus on lifestyle first and then medication or surgery. Because I think if you look at reflux, hypertension, pretty much any medical condition, there's always some type of lifestyle thing, you can do to improve it. So reviewing her sodium content, whether it's the pickles or the rock salt that we learned so much about from Wikipedia now, or limiting sodium intake will decrease her blood pressure in itself and render her medications more effective. Discussing the benefits of physical activity, you guys also brought up. And also kind of the more trickier point here, which was brought up too, was avoiding the non-steroidal anti-inflammatory drugs, or use them only as needed at a low dose. And as you mentioned, acetaminophen would definitely be a better choice, up to 4 grams a day maximum. Yes?
The lifestyle piece is pretty straightforward. Reduce the sodium, increase the exercise. Mm-hmm. For this particular patient, I know this particular patient relatively well. Getting a traditional somebody who's had Indian pickle their whole life is never going to happen. My old mother still carries that around with her in her purse wherever she goes. So you're not going to get her off of that. If you're going to make any changes to the diet for a traditional household, you got to get her husband involved too.
Excellent.
Because
or vice versa.
Whomever she is cooking, they need to be on board as well, because that person is going to be dissatisfied and she will continue to cook for that person.
That's an excellent point. Yeah.
I mean, again, the lifestyle piece is obviously key here, but the biggest bang for the buck, unfortunately, with her is going to end up being drugs. Drugs
in practice, in theory, potentially. And the dietitians have always taught me to bring in the spouses who actually do the cooking in the house, and I think that's an excellent point you bring up. One of my other roles at Sunnybrook is I see patients preoperatively before cancer surgery, and I've had patients just like this who would come in wheelchairs and being booked for a big 12-hour Whipple procedure, and that would often get them motivated. So I work with a therapist, and we get them exercising before surgery. And I've actually seen, quite drastic benefits. I mean, a woman who before wouldn't be a candidate for surgery with motivation for whatever underlying reason, could be motivated, even in this demographic, not to be stereotypical. Alrighty, so I know a lot of this is intuitive, but it's always nice to hear it. So again, lifestyle recommendations for preventing and treating hypertension. So CHEP guidelines recommends less than 2 grams or 2,000 milligrams of sodium per day. And would our dietitian in the room agree? We're good? Good, excellent. So healthy diet would include, high in fresh fruits and veggies, low-fat dairy products, dietary and soluble fiber. It works good for the bowels too. Whole grains and protein from plant sources, low in saturated fat, cholesterol, and sodium in accordance to Canada's food guide that our children are all learning about. Regular physical activity. So recommendation is having at least 30 to 60 minutes of moderate intensity dynamic exercise. I'll explain what this means in a bit. 4 to 7 days per week in addition to daily activities. So advice is one of the things that's free. It's easy to give, but hard to take, or to actually implement. Low risk alcohol consumption, less than 2 standard drinks per day. So we would say less than 14 for men, less than 9 for women in a week. Again, ideally spread out, not all at once. Attaining and maintaining ideal body weight. So again, BMI normal 18.5 to 24.9, and as Ritesh mentioned, depending on the demographics, it's even a bit lower in some ethnicities, like South Asians. And a waist circumference, men again, less than 102, and women less than 88 centimeters. So when we talk about an exercise prescription, often in the Cancer Center, we do actually write it out with our therapist. Many of you may have heard of the FIT principle. Is this novel, or this sounds familiar? The FIT principle in terms of prescribing exercise. Often patients, if they leave with the paper in their hand, you feel like a better doctor, and they feel like they had more to take away from the appointment. So actually writing it out, and we've done many quality improvement projects in our family health team at Sunnybrook in terms of writing it out and looking at adherence, and there seems to be more uptake. So we talk about frequency. So again, exercising at least 4 to 7 days per week. Intensity would be moderate. My therapist often tells patients, you should be able to hear yourself breathing or at least maintain a conversation, but get your heart racing up to a moderate intensity, again, depending on the patient. Time, 30 to 60 minutes, and type cardiorespiratory activities like walking, jogging, cycling, or probably non-competitive swimming. I'm not sure about competitive swimming, but definitely anything aerobic, but also weight bearing. I think I have a lot of patients with diabetes, and I think there's such a big role in weight bearing exercises as well, because often the glucose gets consumed, and I can only imagine it's the same for hypertension.
Yeah, I was just going to add, most of our patients have comorbid conditions,
Right.
such as osteoporosis, in which case you have to add on your weight bearing,
Right.
your balance exercises, and your flexibility.
Right.
So I think we have to work towards more combined approaches.
Exactly. And if you're fitter from a muscular strength, you're likely able to do more cardiovascular activity as well. That's perfect. So exercise should be prescribed. And I think, just practice it for a month. It's really interesting if you try it and see what their uptake is. If you actually write it out and they take it home and reflect on it, it has a lot more impact. It may work for us too. We're good at advising, I don't know, but implementing it ourselves too. So assessment of overall risk. Over 90% of Canadians who have hypertension have other cardiovascular risk factors, as you mentioned. So really looking at diet and exercise, but also all of those vascular risk factors being cholesterol, diabetes, and lipids. So this is her blood work. So if we look at her glucose, is 5.9, so which would be considered normal, as opposed to pre-diabetes 6 to 7, or diabetes higher than 7 if it was fasting. Urea 7.8, so slightly high. Maybe she's a bit dehydrated, would you say, Sheldon? Maybe? Okay. All right. Creatinine of 88, and I think Sheldon would approve with this, not a bad GFR of 63. Her potassium is normal, her hemoglobin's normal. So really maybe a bit of dehydration going on, otherwise quite normal looking labs. Her LDL is 2.55, so we know based on our Framingham study, if she was high risk, we would ideally want an LDL less than 2 or a 50% reduction. If she's moderate risk, an LDL less than 3.5, and if she's low risk, an LDL less than 5 before we start therapy. And again, diet and exercise has a huge impact. So really, she's not too bad, even if she was high to moderate risk. Her total cholesterol is 4.98. Triglycerides are 1.7. So I guess the rock salts aren't that rich in triglycerides. Her HDL, or the happy cholesterol, I tell patients that you want high, is 1.35. So that's looking quite good. And her total cholesterol to HDL ratio, that they actually don't report at Sunnybrook anymore, even though it's a simple math calculation, is 3.7. So again, for a high-risk patient, less than 4, moderate, less than 5, and low, less than 6. And I'm not sure in the community, are you guys using non-HDL, or do you see that reported on your blood work now? So non-HDL is really total cholesterol minus HDL. And what it is that it includes LDL, but all the other lipogenic chylomicrons and VLDL and other things. So the non-HDL is always a few points higher than the LDL. So for a high-risk patient, ideally less than 2.8 is a recommendation for non-HDL. So breakfast. So it's Indian food, and maybe Ritesh can relate, and a few of the other South Asians in the back. So breakfast, she has puri, which is a fried bread, tastes amazing. Chole, which is chickpeas. Halva, which is an amazing sweet dish made from semolina flour. I'm already getting hungry, I know. For lunch, she has paneer, which is a fresh cheese that Indians make, sandwich with canned fish. And for dinner, she had chicken tikka, basmati rice, gulab jamun, which is like a fried timbit dipped in liquid sugar, which is just so amazing, but you can just imagine. And basil tea, which I'm sure is the best of her thing here. So quite an intense diet of her that she should go through. So if you actually break down how much salt is in her diet, and it was a bit shocking, but maybe not so much, at breakfast, again, just translated into English foods, her sodium intake at breakfast is 1,100, lunch 1,400 milligrams of sodium, and dinner whooping 2,500 milligrams. So a grand total of 5,000 milligrams of sodium per day. And we just reviewed that Canadian recommendation is less than 2,000. So she's more than 100% fold higher than where people should be. But it really goes to the point that, before we always think about bumping up the medication doses, there's probably so much that our patients can do from a lifestyle perspective. So what I found very interesting from this graph, you can definitely see, average sodium intake and by age, and how the younger population seems to be consuming more salt, whether it's just higher appetite or whatever than as you age. But it was also interesting for me to see that the average sodium intake in India was 3,300, and in Canada it's actually 3,500 milligrams per day. So despite the salt that we love in our diet as Indians, in Canada we're actually on average consuming about 3,500 milligrams of sodium a day. So definitely higher than the 2,000 that we recommend. This was a really interesting study looking at urban cities and rural cities in India. So some urban ones would be Mumbai or the old Bombay, Chennai, and some of the rural places like Rajasthan and Haryana. And definitely a higher consumption or prevalence of hypertension in urban areas, whether it's the factor of stress or access to McDonald's, higher salt foods, but definitely the rural areas, where they're probably more active on the farms and other things, consuming maybe healthier diets, actually had a lower prevalence of hypertension. And when you look into socioeconomic factors, we often say low socioeconomic status is correlated with more disease, and often rural areas have a lower socioeconomic status in general, but yet we saw less hypertension, which is really interesting. So what does 2,000 milligrams mean? I mean, it's kind of hard to conceptualize. So for the scientists in the room or chemists, 87 millimoles of sodium, 5 grams of salt, or what's more practical for me is actually only 1 teaspoon of table salt per day. So, that seems quite less, and I'm curious if our dietitian has any suggestions, in the room, but, 1 teaspoon is not even a tablespoon. And if we think about the bread we're eating and so much of the food inherent is in everything. So is it easy to achieve? Because in my mind, it seems quite less.
I don't like to say 1 teaspoon of table salt to patients because I think that's added salt. And so really focusing on label reading and, showing them the bread and the milk and everything, even healthy foods, it is accumulative, so it's in everything.
Right, exactly. And we'll get to that in terms of looking at labels.
And I would like to comment on her diet history.
Yes.
She had, besides some onion and canned tomatoes, absolutely no vegetables or fruit in her diet. So talking about the potassium coming from fruits and vegetables, maybe just balancing that, and it's a really big thing.
And not deep frying the vegetables as we like to do, but eat them raw too.
It's not a vegetable, that's what they go.
Excellent points. Thanks for sharing that. So, but just to conceptualize, if you think about it, 1 teaspoon of salt, additive in everything, what's inherent in our foods plus what we add, is equivalent to 2,000 milligrams a day. So 80% of average sodium intake is in processed foods. We're not surprised, and only 10% is actually what we add at the table or in cooking. And often I tell patients try to avoid adding salt on top of your food, and as a starting point to reducing salt intake. A very interesting meta-analysis in the Cochrane in 2006 that compared the effect of reduction of sodium on blood pressure. And they compared at the top patients who have hypertension and patients who are normotensive. And we can see that the same or very similar reduction in salt had a bigger impact in lowering blood pressure in patients who have pre-existing hypertension. So just to show that I think a lot of the underlying process of hypertension, although we call it essential, is often a lifestyle factor as well. So reducing average sodium intake by 1,800 milligrams per day can reduce your systolic by 5 and diastolic by almost 3. So it may almost get her into a healthier zone if we even look in our patients just by having that dietary change. And she still won't be acceptable according to the 2,000 limit. So we may have heard of the DASH diet, and I remember what it stands for. I think it had a very nice pun. Someone to help me here what the DASH stands for. It is the Dietary Approach to Stop Hypertension. So I think it's so well named. It's very similar to Canada's Food Guide. And it's really reducing sodium in the diet. So sea salt, kosher salt, fleur de sel are high in sodium, and they're actually not better than table salt. So a lot of people think I'm eating a different form of salt, but a lot of these actually have a very similar sodium content. So the DASH diet is advising patients to eat a healthy diet according to Canada's Food Guide. As you pointed out nicely, incorporating more veggies and fruit every day, 7 to 8 servings, having more whole veggies and fruit than as opposed to juices, which are often way higher in sugar. 2 servings of low-fat milk products each day, using whole grain, higher fiber grain foods, so breads, rice, cereal, pastas. I often tell my Asian patients, instead of, white flour, try to use, brown flour, instead of white, rice, even any patient, using brown rice as an alternative. Small amounts of lean meat, poultry and fish, and frequent use of legumes, seeds, and nuts. So she does have a bit of chickpeas in her diet too, which is good. So to reduce her sodium, dietary sodium intake, again, educating her to buy lower sodium foods. Big culprits are often juices, soups, I remember a patient I had when I was at McMaster who was in with heart failure, and we kept diuresing her, but she would never, get the fluid off her. And we found out she kept going down twice a day to Tim Hortons to have a nice salty soup. So despite us going up on her furosemide, she would just take all the salt in. So it would kind of counterbalance all the efforts we made.
We had a food guide on your prior slide.
Yeah.
And you look at all of those foods that people are supposed to be eating. In principle, when you look at the idea behind weight loss and that fat is actually attracts fluid, it would be beneficial to actually decrease the intake of your food in order to lose weight, lose some of that fluid, and get your blood pressure down. Because if you eat all of that a day, that's a lot of calories.
Right.
So I would like to hear from the dietitian to let us know, we want to promote Canada Food Guide. We want to promote the DASH diet, but we don't want our patients putting on weight.
Putting on more weight, trying to be adherent. Any thoughts in the back?
I don't use Canada's Food Guide. I started in January with the stroke clinic, and I've given all my food guides away, except for the diabetic food guides. I do find them, they're really useful in looking at portion sizes, and they don't give the same amount of carbohydrate. There is another dietitian in the room, so I would like to.
Okay, sorry to pick on you all the time. My apologies.
I work for a diabetes education center, and we do use Canada's Food Guide, but we tend to use the Canadian Diabetes Association Beyond the Basics, just to give more specific direction for diabetes management. The one comment that we always tell people and stress using Canada's Food Guide is it's important to look at the serving sizes. So even though it sounds like it's a lot of food, one serving from vegetables and fruit
is actually not
half a cup.
Right.
So you're not going to get a lot of calories with those foods, and you're going to get a lot of potassium. So I don't think Canada's Food Guide is as high in calories as we tend to think.
I think it is.
And one comment that I had about the sodium, I find most patients that I start working with to reduce the sodium, they immediately say, oh yes, I'm following a low sodium diet. And they think that by not adding salt at the table, that they're not having a high sodium diet. So they don't even take a look at what they're eating in their foods.
Excellent points, I think, all of them. And really looking at serving sizes and having everything in moderation. Completely agree. Yeah, a good balanced diet. Perfect. We're doing for time, so not too bad. So going back to labels, so using, I think the point here, the percent daily values. Often when I educate my patients, I say look at the labels, and ideally there should be less than 5% of your daily value of sodium required in whichever food choice they choose. So it's a great way to compare different food items when you're at the store. And again, preparing home-cooked meals with little or no salt. So to reduce dietary sodiums, kind of the do's and the don'ts, so using less salt in high sodium foods at the table, ketchup, mustard, pickles are high culprits, eating less restaurant meals, advising patients not to add table salt, as we brought up, and eating foods with more than 360 milligrams of sodium or more than 15% of your daily intake. So again, ideally less than 5. So we got 2 more quick questions left in the case before we break. So the second question is, how does excess sodium intake, more than 2 grams a day, actually increase blood pressure? So maybe just for the sake of time, we can pass the mic around if anyone has any thoughts or hypotheses on this.
The body's pretty good at holding on to salt.
Yeah.
And so with it will have to come water.
Yeah.
And so if your total volume is increased, then your blood pressure's up.
Right. It's almost like when you're at the movie theaters, it's like a tactic, right? The popcorn's so salty, then you have to buy drinks because you get thirsty, and it draws water like osmosis, and it just increases your blood volume, increases your blood pressure. Exactly. Any other thoughts? Or we'll go through it. So there's actually a lot of mechanisms by which it works. So all of the 4 are correct, and I'll go through each one individually. So exactly what Ritesh mentioned, the immediate acute effect is dietary sodium excess is to promote water retention and expands the extracellular or circulating volume. So if you have salt in your bloodstream, draws water to it, increases your blood volume. You have more venous return to the heart, increases the blood pressure as well. Another mechanism on how sodium increases blood pressure is that more chronically. So after months of sodium dietary excess, the capacity of sodium excretion diminishes as the excretion threshold is adjusted upwards. And not sure if Sheldon has any other thoughts, but really the more sodium you take, it affects the threshold and the renal excretion, so you actually start retaining more sodium as well. The third thing would be peripheral resistance, so a direct effect on excess sodium exposure decreases arterial compliance independently of blood pressure level. So effectively what's happening is that you have more resistance in the blood vessels as well with prolonged high sodium intake. And the last mechanism, or I'm sure there's more, but the last one we have here is excess sodium will bring on endothelial dysfunction and therefore decrease the dilatory capacity. So again, if you can't dilate as much, you have a tighter tube in which the blood has to flow, so therefore more resistance and higher blood pressure. So not only the effect of drawing water in, but also the effect on the actual vasculature itself and the renal threshold of excreting sodium. So again, similar to diabetes, hypertension, as we talked about, can have effects on both the microvascular and macrovascular systems in terms of complications. And the last question we have for the case, so independent from its effect on blood pressure, how can excess sodium intake cause organ damage? Not only does it affect blood pressure, but it actually has an effect on end organs. So we'll go through this one by one, I believe, or over here. So, again, causing endothelial dysfunction, aortic stiffness, just like all the other vessels. It can contribute to left ventricular hypertrophy as well as chronic kidney disease. So sources of sodium within processed foods in Canada, down at the bottom, to go to pizza, sandwiches, all the good stuff, unfortunately, has so much salt in it. And if you compare it to healthier food choices like cereal and potatoes, and really, again, I think it just shows the value of sitting down with our patients, taking a proper food history, and really looking for opportunities. The soy sauce, it's off the chart. Okay. And so case progression. So who wants to read one of the last slides for us to help me out?
After counseling with Levina on lifestyle modifications and the impact of high sodium on blood pressure, she was committed to avoiding canned foods, limit sauce and condiment intake, not to use salt freely, and discard baking soda. Change to small amount of unsalted butter, eat more fresh fruits and vegetables, and her ambulatory blood pressure monitoring after 3 weeks. Of dietary counseling, 24-hour average, I'm having some trouble seeing, 136 over 84, daytime average 142 over 86.
So I think it's just amazing to see that in this particular case, which is actually a true case, is that without even increasing the dose of medications, we already got a systolic down by almost 10 points, which is, I think, is profound. Again, the ideal patient who actually listened to the advice we provided them. So 3 months after her original visit, she's walking 30 minutes, 3 to 4 times per week. She continues to apply dietary changes. She has no complaints. Her weight went down about 30 kilograms. Her blood pressure average in clinic is now in the 140 over 88 as opposed to the 156 we saw before. And the rest of her physical exam is unremarkable. So again, I think this just summarizes how we talked about if we can reduce even 1,800 milligrams of sodium in our diet, it has a profound effect on the systolic and diastolic blood pressure. But we talked a lot about sodium, but lifestyle, as we started earlier, the impact of weight loss, again, having a significant effect. Alcohol, increasing our activity, can also decrease blood pressure by about 5 systolic and 4 diastolic. And following the DASH diet, I think profound. A decrease by 11 in systolic blood pressure and about 5 to 6 in diastolic. So I'll just move through this. I think it summarizes a lot of the same things that we're talking about. And if we look at weight as a modifiable risk factor, decreasing your weight by about 1 kilogram can decrease your blood pressure by about 1 systolic and 1 diastolic. So definitely quite additive in itself. So 25 to 30% lower risk of cardiovascular events were seen in patients with lower sodium groups in this other study in the BMJ. And this was only after achieving about a 1 gram reduction in sodium per day. We already know Canadians are consuming about 3,500 milligrams of sodium as opposed to 2,000. So even if we can reduce them by 1,000 milligrams, we can reduce hypertension by almost a quarter. In Canada, huge savings. If we could save so much money, we don't have to pay the $2 on the DVP that's being proposed. So I think, if we actually look in 1 million fewer hypertensive Canadians, we only have 30 million Canadians. So I think a 25% reduction could be achieved just by implementing, if everyone ideally implemented the DASH diet and followed our recommendations, and huge in the millions, in terms of savings for the healthcare system. And obviously, it's not just reducing blood pressure, but also the impact we can have in reducing complications, coronary disease, heart failure, stroke. Again, from an economic analysis, huge savings. So just in summary, again, we looked at a lot of medications earlier this morning. This focus of this particular case, again, there's many cases that we have as part of our program, was to focus on lifestyle. And again, ideally reducing sodium up to 2 grams per day, weight loss, achieving a BMI ideally less than 25, reducing alcohol to about 2 drinks per day, using the FIT principle to exercise more, give exercise prescriptions, 30 to 60 minutes of exercise 4 to 7 days a week, following the DASH diet, not smoking, and working on the belly fat to reduce. So key learnings, I think, really to high dietary sodium is a key contributor to blood pressure. There's a lot of processed foods, a lot of opportunities to improve if we actually sit down and look at what we're eating with all of our meals. Really consider reducing sodium towards that 2 grams per day, or that 1 teaspoon of salt. And again, improving more than one lifestyle has an additive effect. It's not only the DASH diet, but the fact that she lost weight, was exercising more. All of these together has a profound impact, but pharmaceutical companies won't fund it because it's not profitable. And as Dr. Tobe and Ty mentioned, Hypertension Canada has a host of resources. I use it all the time with our medical students and residents, and definitely you can use these presentations and those as well to educate your colleagues and pass on that thank you so we can have that exponential effect on health literacy. All right, thanks so much. Time for break.